David is the current president of the American Hernia Society. I know him well. I've attended a lot of hernia ski conference summits in North America with him, but he's more known for his world-leading expertise in groin pain. He's also the director of the Liechtenstein Amid Hernia Clinic and a professor of surgery at UCLA. He's going to talk to us on groin pain, when to intervene.
Hello, my name is Dr. David Chen, and again, I'm a professor at UCLA. I'm director of the Liechtenstein Hernia Clinic, and I have no disclosures for this. I'll be talking today about timing of intervention in groin pain. So I'd like to start with this quote: "A surgeon can do more for the community by operating on hernia cases and seeing the recurrence rates low than operating on malignant disease." And I think that we need to rethink this and also include the statement "and chronic pain rates," because when we talk about what patients care about, it really does center around their quality of life and the rates of pain that they have thereafter and their function. This is a picture that a patient made for me. It had years of chronic pain, and this is his crying Buddha coming out of a mesh. But as I tell every patient, every surgeon wants to provide the best possible care to each patient. But definitely, inguinal hernia repair, despite being as good as you possibly can be, the rates of pain can never be zero. So our goal as good herniologists and as interested surgeons and thoughtful practitioners is that we want to reduce the rate of our recurrences and chronic pain to less than 0.5%. So we have to always remember that all repairs can cause pain. Anterior techniques have more direct exposure to nerves, whereas laparoscopic techniques have indirect exposure to the nerves. And it's important to remember that the problem preceded mesh and tissue repairs, they cause pain as well. So all techniques, though, can be optimized to minimize pain. And pain is a function of the denominator. Whatever technique we're doing more of, we'll have more patients with pain. So what are the causes of chronic pain? There's nociceptive causes, inflammation, meschoma, neuropathic causes, nerve injury and scarring. There's somatic and visceral pain, and it's challenging because there's a lot of overlap between the signs and the symptoms, as well as psychological, social, and genetic factors. Nociceptive pain, though, is really this kind of tissue injury, inflammation. It's mediated by A delta and C fibers, the nociceptors, and you perceive that as aching, squeezing, stabbing, throbbing pain. You can see also this kind of nociceptive pain from meschoma. You can see this is what Parviz described in 2004 in this article. But I always tell patients it's kind of like having a foreign body in your pocket that you really just can't get rid of. What are the problems that mesh can cause? Obviously, that's a very salient topic these days. So infection, pretty uncommon, but it can happen. Anterior flat meshes can contract, wrinkle, or fold. Plugs can extrude. They can migrate all over God's creation. They can be rigid. 3D gadgets like bilayer meshes can also change configuration, extrude, cause meschoma. Tep and tap can clamshell, fold, or extrude. Here you can see many examples of what mesh, when it went in, probably didn't look like this, but when it came out, you see it's all kinds of different configurations. There's an article from 1988 from the Liechtenstein Institute, and I like to show it because it shows you that when we published our first series with patients with pain, this was in the non-mesh era. So pain is also a function of complex neuroanatomy of the inguinal canal. Neuropathic pain can be caused by direct nerve injury, shooting, stabbing, burning, electrical sensations manifest as hyperalgesia, hyperesthesia, or hypoesthesia or paresthesias. And you can cause that either by mechanical causes, you see a nerve put right through the nerve here, or from ultrastructural causes, that the nerve in apposition to scar or to mesh can be injured. It's always important to remember that the anterior nerves, there's a lot of variation, both anteriorly and posteriorly. But here's an ilioinguinal with 9 branches, had 3, 6, 9 here. So very difficult to not get into trouble with that kind of a nerve. And here, Wolfgang Reinpold showed us with a cadaveric study that the exit point of these nerves is really quite variable all over, both above and below the iliopubic tract. So to just say that, oh, I just only tack lateral and superior to the iliopubic tract is still not foolproof in terms of saying you won't injure something. So if we want to think about how to treat chronic pain, we have to say, what's the cause? We have to try to understand the cause. We have to think about the neuroanatomy of the groin and say, what's likely the mechanistic cause? You need to know what happened at the original operation or the prior operations if they've had several. And you need to have a tailored approach of how you're going to approach that. So we need to understand what goes wrong. So with anterior repairs, it can be mechanical pressure of hernia devices, entrapment by mesh, by suture, by perineural scarring. You can have traumatic neuromas or direct contact of nerves with mesh or damage to that investing covering of the investing fascia over the nerve. So you can see here mechanical pressure that these things fold, they capture nerves, tacks can capture things. You can see here nerve entrapment right here, tack right here, suture right here. In a tissue repair, this is from a Bassini repair here, you can see nerve trapped right by suture. Staple right on the nerve here. This is a Liechtenstein with the medial suture run. Just will trap the ilio hypogastric nerve. Similar here, ilio hypogastric nerve is trapped. You can get a traumatic neuroma after anterior repair. If you mobilize the nerve, as we talked about, you can then have where the nerve becomes injured, especially if it's in apposition to mesh. What about in an open and laparoscopic posterior repair? You can have nerve injury or entrapment from inadequate dissection, from an incomplete view of the myopectineal orifice, from folding or migration of mesh, over dissecting the triangle pane, putting mesh in the parietal compartment where it will scar to the nerves, or defect closure, you can trap the nerve. So if you don't fixate, you only need to think about really the genitofemoral and the laterofemorocutaneous. You can see here, though, that there's a lot of variation. 4 branches of the genital, 2 branches of the femoral, 2 branches of the laterofemorocutaneous nerve. So there's a lot of potential for injury. You can see here if you over dissected the mesh or if the mesh scars to the nerve, you can see that that can cause some neuropathic pain. But if we tack or if you suture, you now have to think about the iliohypogastric and ilioinguinal. So when I see something like this, we always talk about it like playing the game Battleship, that you just don't know what's on the other side, and you can just get unlucky if you use penetrating fixation. So we try to say avoid it. And even in robotic repairs where we have a real huge ability to suture, the problem is here, if you don't know what's on the other side, you can trap the iliohypogastric nerve, like in this case where the patient had neuropathic pain, but great hernia repair, but you just unfortunately caught the nerve. And I've seen also the entire cord transected by suture. So what do we do to treat chronic pain? You want to have a standardized algorithm, should be multidisciplinary. Most patients won't need surgery, so expectant management will work in most patients. Pharmacologics, behavioral therapy can be helpful. Interventions such as nerve blocks or ablation. And what do we operate on? So neuropathic pain and meshoma are perhaps the most common things that we'll tackle. So when you look at this diagnostic evaluation, you want to look at all the op reports. You want to look at cross-sectional imaging to rule out something wrong with the mesh or other causes. MR neurography is sometimes used. You can use injections, blocks, and they can be very revealing in terms of is this a neuropathic problem. If it works, it definitely gives you a piece of information. If it doesn't work, it may be operator dependent. And then we also use quantitative testing with sensory heat and cold sensation, monofilaments, pressure algometry. So different things that are more academic that we can study. But when we look at cross-sectional imaging, we're looking for, do we see a plug? Do we see any other pathology? Do we see orthopedic injuries or gynecologic injuries or things like, or urologic injuries that could account for this pain? First-line treatment options, analgesics, limited narcotics, lidocaine patches can be helpful sometimes, neuropathic medications, pregabalin, gabapentin, atypical antidepressants, physical therapy. Cannot stress enough the role of cognitive behavioral therapy, psychiatry, and really having where patients address some of the psychologic aspects of their pain as well. And then nerve blocks, usually we'll use a local anesthetic or steroid. So the mechanism, as we said, you need to think about all the different things that cause the pain, and then how are you going to get to it? So when we think about all the different types of inguinal hernia repairs, you have to then tailor your operation. Am I going in the front, above the transversalis fascia, or am I going posteriorly behind into the preperitoneal space? Or do I need to go to the retroperitoneum and get the nerves proximally? So mapping, dermatomal mapping, Rigor Alvarez really helped us to solidify this. And this allows us to tell us which nerves do we think are involved. So here, zeros are normal, plus is pain, minus is numbness. And you can see here, this is probably ilioinguinal, Ilio Hypogastric. This is probably from a lap repair because it's higher than any inguinal incision. This is probably going to be lateral femoral-cutaneous from a TAC or a dissection of the LFC with a laparoscopic repair. But it gives us a universal language that we can talk about this on IHC, on different venues, and we can tell patients, well, from this pattern, potentially looks like these are the nerves involved, or it doesn't follow a pattern. And remember, this is really beneficial only for neuropathic pain. It doesn't really help you as much with patterns for nociceptive pain. What are the surgically correctable problems? So infection, recurrence, meschoma, neuropathic pain, and arcalgia. And so we'll talk about this here. So recurrence, you can have a repair, it misses, patients have pain from the recurrence. You can also have a pseudo-recurrence, a retained cord lipoma, where nice laparoscopic repair on this side, but on the other side has this big hamburger-sized cord lipoma. Feels it as a hernia still. So when do we operate on recurrence? Timing of intervention. So in a proven recurrence, you intervene when it's just like a normal hernia, when it's symptomatic, or if you have a hernia-related problem. Okay, so what about mesh? If it's a mesh-related problem, when do we intervene on mesh? So mesh removal can be done open. This is a bilayer mesh here. You can see how that's folded. It can be done laparoscopically. This is a clamshelled, very firm mesh. This is robotic mesh explantation. So all different ways. When do we approach mesh? Well, the timing of mesh, you really want to wait for mesh problems. You want to give them a minimum period of 3 to 6 months, conservative management to allow for integration, scar tissue maturation, that you expect the mesh as it integrates to soften. And you want that acute phase healing to pass. So really try to kind of conservatively manage the mesh patients. And then after that time period, though, you really kind of plateau and you say, okay, if we need to do something, so be it. How about neurectomies? We can do that open. Here, open extended, where we go through the floor and get the genitofemoral. You see how we do a neurectomy. We basically ligate that nerve at its exit from the internal oblique. And you see that I'll usually close the neurolemma. And then here we just bury that nerve, grabbing that suture and dragging it underneath the internal oblique muscle. So, or we can do this laparoscopically or retroperitoneally. So when do we go for nerves? Well, same thing. So with neuropathic pain, doesn't mean you don't treat them, but you want to initiate therapy as soon as symptoms arise. But that's typically pharmacologic. So pain medications, neuropathic medications. You can then try interventions. Blocks can be attempted anytime when symptoms warrant further intervention. And then surgical, though, we really do recommend for nerves to wait a minimum period of 3 to 6 months for the same reasons: scar tissue maturation, acute phase healing. And this is kind of an algorithm that we published in Hernia with a consensus group of pain hernia surgeons that were interested in pain. And really you see that most of the time we'll say wait 3 to 6 months. And then here you want to you basically burn all your bridges and then operate if you need to. We'll talk about different circumstances of when you might want to intervene early. So especially with excruciating pain, you might warrant early intervention. Now, what about arcalgia? So 2 to 3% of the time, patients have coexisting testicular pain, and this is not from the genital nerve, but really from autonomic and paravasal nerves within the testicle itself. And we learned this from a patient that already had a vasectomy where it was stuck in the plug. When we removed it, we could see that there were all these nerves that were injured in the lamina propria of the vas deferens. And so we started to strip the vas both in open fashion and laparoscopically and robotically to where we could then mediate some of this arcalgia. So when do we do this? Well, it depends. So if you have testicular pain, a cord block can be done anytime. Acute ischemia or torsion, obviously you should do that right away because that's high intensity pain and it's caused by ischemic event. Chronic ischemia, where the testicle shrinks, or orchitis, you want to typically conservatively manage this and let it declare itself. And then cord denervation, paravasal neurectomy, if I'm operating for other reasons, we can do it at the same time. Otherwise, if they go to the urologist, just, kind of with the way we approach it when it's necessary. And then orchiectomy for refractory pain. Okay, so you can do that. I would burn all bridges first. What are the exceptions? When do we operate early? So infection, acute severe pain. So come out of the OR and patient, is right in the recovery room or the next day, and they have pain out of proportion that that's just not normal. Think about bleeding, acute nerve entrapment or disruption, and take them back if you really feel that there's no better time, no easier time to fix a problem. And I know that's hard to do that, but that's kind of the right move. Visceral symptoms, ileus or obstruction, always have your radar up for something that's going amiss, and any motor deficit should be addressed. So here you can see infection. This, as soon as you find it, need to deal with infection. So sometimes you can try a period of antibiotics if it's an indolent low-grade infection, but otherwise, just go deal with infection. Fistula, so visceral symptoms here. There's a patient that you see that erodes right into the sigmoid colon, nice mesh entrapment right into the sigmoid, and we did a mesh removal and did a partial sigmoidectomy here. So this is a guy that was in a wheelchair from a lapping inguinal hernia, and so you can imagine if you have a true motor deficit, you just try to deal with that as soon as possible because otherwise it's not going to come back. So here you can see, remember the femoral nerve lays lateral to the psoas, so you don't always see it so clear, but it's there. So patient selection is the key for remediation. Treatment should really begin immediately when we're talking about pain. Even though you're not going to operate right away, you want to treat immediately and not ignore it, because otherwise the mechanism for becoming chronic pain is acute pain. Infection should be treated when identified, recurrences treated based on symptoms or complications. Neuropathic pain and mesh, try to be conservative, wait at least 3 to 6 months, 6 months in mesh-based cases. Early intervention may be considered for acute severe pain, visceral or motor symptoms. And remember, prevention is the most effective treatment with all of these things. Just if you don't have pain and practice good technique, your patients will do better. Thanks for allowing me to participate. I hope to see you all in Austin in September.
Okay, so that was another very educative and power-packed talk by David Chen. There are tons of questions which obviously we would not be able to handle at this point. So what we are doing is the team is curating these questions, and we will throw them up in a Facebook Live discussion that we will announce soon enough. And so we will have another interesting session maybe in Facebook. So I'll conclude this session. Thank you very much.